Assalamu alaikum ji. My name is Dr. Shahzad Ahmed. I'm a fellow in interventional radiology, Shifa International Hospital. I welcome you to the Thyroid Thermal Ablation workshop being held in Shifa, Islamabad. It's a 2-day workshop. I welcome all the participants that are present in the hall. I also welcome all the participants that are joining or about to join us on Zoom. We will have a Tilawat session right now. Then we will have 4 short sessions of 20 minutes each, followed by a question answer session at the end of every talk. The sessions will be RFA basics, technique of thyroid RFA, indications of thyroid RFA, and followed by complications. We will have a tea break, a souvenir distribution as well, and then hands-on training on a phantom model for all the in-house participants in the hall. Our chief guest, our speaker, our mentor today is Dr. Shahzad Ahmed. He will be joining all the way from, he's present in the hall. He has come all the way from Salt Lake City, Utah. That's where the 2002 Olympics, Winter Olympics were held. I have just highlighted few of his credentials. They are long but impressive. Well, he's a member of American Board of Medicine, and he has been practicing in Salt Lake City, Utah. He has done the most number of RFA procedures as an endocrinologist in USA. He was also the first one in North America to do an RFA of a parathyroid tumor. He has done his residency from Mount Sinai School of Medicine and his endocrinology fellowship from Harvard UCLA. Currently, he's an assistant professor in San Francisco School of Medicine as well. So I welcome you here. Thank you for coming. First of all, we're going to start our procedure and our session with Tilawat. And then we are going to have a RFA basic session as well. Thank you.
Bismillahir Rahmanir Rahim. Wash-shamsi wa duhaha, wal-qamari idha talaha, wan-nahari idha jallaha, wal-layli idha yaghshaha, والسماء وما بناها والأرض وما طحاها ونفس وما سواها فألهمها فجورها وتقواها قد أفلح من زكاها وقد خاب من دساها كذبت ثمود بطغواها إذ انبعث أشقاها فقال لهم رسول الله ناقة الله وسقياها فكذبوه فعقروها فدمدم عليهم ربهم بذنبهم فسواها ولا يخاف عقباها.
Jazakallah. Let me also just say that we are going to have a live case session tomorrow as well. We have a patient. We are going to do RFA. So all the in-house participants will be entertained with it, inshallah. So let me just start the proceedings today with our first topic of RFA basics. I welcome Dr. Shahzad, if he can just take to the podium. Thank you, sir.
Assalamu alaikum. Thank you so much, everyone, for coming and joining us. Thank you for the very gracious introduction. My name is Shahzad. I'm an endocrinologist, but my work is thyroid only. That's all I do. I used to be an endocrinologist, so I've been doing this 20 years. So last 4, 5, 6 years, this is thermal ablation interventions is what I pretty much do most of the time. And so we're going to go through all of these things. We'll try to keep it informal so we can take questions. I don't know how we could take questions from the people who are not here. It's going to pop up on the screen. All right, perfect. So you guys can let me know, and then we'll do it in short stretches, 20 minutes, and we'll stop and we'll talk because it's not that complicated, but it's kind of new. So we'll go through it. I mean, IR people probably know about this already because you guys do it for liver and other lesions and bones. So it's slightly different with some subtleties when it comes to the thyroid. And so, which is why it took a long time to get this thing started in the US, even though RFA was available for other tumors for 15 years. Only 2 or 3 years ago did this become mainstream in the US. So you guys know about the basic techniques. I'm not an expert in physics, but It's basically friction heat. That's what we're using. It is alternating frequencies of current inside the antenna, internally cooled. It goes from 5 watts to 30 watts, not a lot of voltage, but the change in the frequency of the electrical current will cause agitation around the tip of the uninsulated part of the antenna that will cause heat to develop and basically lead to tissue necrosis. And that's what we want. It's important to understand the differences between RFA and microwave and other thermal ablation procedures. Cell death will happen here at 60 degrees. You're not trying to burn the place. You're basically trying to cause cell death, which will happen even at 60 degrees. But if you stay long enough in a sensitive area, even at this level, cell membrane integrity goes away. So 60 degrees is what you're trying to get to. 100 degrees is where water boils. So you don't need that much heat. The difference between this and microwave is that you can't control the heat around the tip of the antenna. Sometimes charring can occur with microwave antennas. You can go up to 300 to 400 degrees centigrades, not routinely, but that can happen. Laser also works on a similar concept. You're trying to get cell death to happen. So that's what this is doing. Now, important thing to understand is that in RFA, you need internal cooling of an antenna. You need it because without that, there's carbonization that happens around the tip of the antenna. So every time you guys are doing RFA, you always have water circulating through the antenna. And the main reason is that the ablation zone alters if you don't have internal cooling. It is not as predictable and reliable. You want a nice ellipsoid area around the tip of the needle where you can burn as much tissue as you need predictably and safely. So you need to know how many millimeters in front of the tip of the antenna you're going to be zapping. If you get carbonized, the needle starts looking like this, and it stops delivering energy. So always have really cold normal saline. Understand that the circuit inside the RFA antenna is sterile. It's not water that is going to be leaking from the antenna into the tissue. So that doesn't have to be sterile, but the rest of the procedure is a sterile procedure. So important concept to understand, internal cooling is vital. And our goal is not to boil the tissue. It's basically to get to 60 degrees centigrade. And that's enough. That serves our purpose. Okay, so this is important to understand. I don't know how many of you guys do thyroid biopsies here regularly? Most of you. Did you guys do it from the head end of the bed, or do you stand on the side of the bed? You guys do it on the head end of the bed. So that's something that's very common in most interventional radiology, people that I've spoken with all over the world, especially in the US. Most endocrinologists or most people will do it on the side, on the right side or the left side start. But this is really important to understand because you have to be here because you're always going transismic, going across. And so this is something you have to start practicing before you treat your first patient. Learn how to do biopsies and procedures sitting at the head of the bed. It's the ideal position. Same concept going all over again, friction heat. This area is going to have more cell death. And basically after that, there's less and less dissipation of the heat. You can predict the area that is going to ablate based on the tip of the antenna. You use a 0.7 centimeter antenna, you're going to have a smaller ablation zone. You have 2 centimeter antenna, you're going to have a bigger ablation zone. If you have a 0.5 centimeter antenna, you're going to have a smaller ablation zone. Okay, so this is very important for us because you can see the tip of the needle when you ablate. Let me rephrase that. You should always know where the tip of the antenna is before you start ablating. You need to know exactly where you are. Because the neck, there's a lot of other sensitive areas which you're going to go through that you want to avoid. And so understand that it's going to predictably ablate about 2 to 3 millimeters in front of the tip of the antenna. So don't go too far and trust this measurement. This is important. So you have to have a margin of safety. So for example, something vital or sensitive is here. That's about 2 to 3 millimeters. Withdraw the needle a little bit, and you're going to basically zap this area and leave whatever sensitive structure in front of it safe. Okay. So different antennas, different ablation zones. Important concepts that we're going to talk about from this point on is the moving shot technique. So what is a moving shot technique? So when this technology was first utilized in the early 2000s in Italy and other places, they didn't get very reliable or impressive results because they were putting the antenna into the lesion and leaving it there and hoping that this is going to cause an ablation. But with time, especially with Professor Baek, one of my colleagues and mentors in South Korea, he realized that if you keep moving the antenna back from the area and basically allowing the needle to antenna to zap the areas that you're withdrawing, you get a much better, bigger ablation zone. So understand that you have to move the needle. You got to keep moving away from the target. You get to the area that is the target area, you start the ablation, and then you withdraw slowly. Overwrapping basically means that if it's a big enough sphere, you're going to do one area, then the second, then the third, then the fourth. In your mind, you conceptualize this thing as a sphere, and you do different quadrants at a time. You move from one area to the other, then you overwrap, you get to the second quadrant, the third quadrant, the fourth quadrant. This is a technique I'm going to emphasize again and again and again. So you mentally start looking at every nodule as a sphere, and you plan in your mind, which areas am I going to be able to target and how I'm going to progress from one zone to the second, to the third, to the fourth. You have to plan this out in your mind, and that's an important thing. And that just basically is a habit that you start learning. So this is going to be a small video which will show you how this burns basically in lab model. Okay, I don't know what's going on here. This should play. Can anyone help me with this? Do I need to hit some button here or click on this? Let's see if this works. All right, never mind. I guess it's not going to work. We'll go to the next thing. You'll show, yeah, here we go. So as you can see, very reliable ablation zone. And this is the moving shot. He's withdrawing. And in a minute, a little more withdrawal, a little more withdrawal. So that's the moving shot technique. Any questions about the moving shot technique? It's pretty self-explanatory. It's not that hard. This is, what do you mean? Oh yeah, this zapping, it's real time, yeah. It's real time. It takes about this much, but this is not an accurate depiction of human tissue. So this is dead tissue. In human tissue, you have a lot of vasculature, right? And so what do vessels do? They're what we call a heat sink. They're going to basically take all the energy and heat away from the tissue. So you have to stay there longer. So it's a little different. But also, as you'll realize, if we do more than 1 or 2 cases tomorrow, the ways different nodules pick up and conduct energy is vastly different. It varies from a person to person. There are some nodules which light up like a Christmas tree after 2 or 3 zaps, and there are others which take a lot more energy. So there's no prediction for that. It's hard to figure that out. But yeah, this is how it works on a lab model, which is what we're going to do this afternoon on phantoms. So transseismic approach is the next important concept to understand. This is a rule that you have to stick with. There will be times where you're going to be tempted to go transverse to, if the transducer is like this, you feel like, oh, this is much easier to access. You must never do that, because you will not see the length of the antenna in its entirety. So that should never happen. So this is something you have to practice. Now, why do we do a transisthmic approach? So if you're going through the isthmus right here, this is the trachea, and this is where the recurrent laryngeal nerve is. This is something you can't see. This is the most common nerve injury in radio frequency ablation. Now, if you go like this, transisthmic, the tip of the antenna is always going to be away from the danger triangle, where the recurrent laryngeal nerve is. Now, there are other sensitive things around here also. I'm going to talk about that. But this is the most common complication. And so always, always, always transisthmic. You will be tempted. There'll be times when you, even if you've done 50, 60, 70 cases, like, oh, the lesion's right here, I could just go from here. You must never do that. You can do everything transisthmically. And so when it comes to benign nodules, when it comes to recurrent papillary thyroid cancer in the neck, or medullary cancer, other cancers, they present their own unique set of challenges, and in different areas, so try different things for that. But that's not more than 5 or 6% of what you do with RFA. Mainly it's for benign nodules. So again, if you had a nodule here, you would plan these overlapping zones like this. Just keep going. Moving shot technique here, here, here. And this is going to basically show you, this video will show you how this is done. Here we go. So this is a real case. And as you can see, the antenna is transisthmic. And this is an ideal type of nodule to zap, because it's really up in the anterior. It's not in the tracheoesophageal groove. As you can see, the ablation is doing really well here. It's going to withdraw and then overwrap. And again, you're staying away from the nerve. This microbubbling is a good sign that ablation is being successful. You're seeing tissue becoming ablated. You can move back. This is a visual sign of successful ablation. But another sign that you'll use on this machine is the impedance, which looks at the resistance to electrical current through tissue. The impedance above 140, 145 basically means the tissue is no longer viable. You've done a good job. It's zapped, it's burnt, it's ablated. There's no inbuilt, integrated temperature sensors in any of these antennas. So you can't basically look at the temperature like, did I get to 60 degrees centigrade? Am I done? That's not there. You can look at this and then you look at the impedance. And so those are two good guides to tell you that you're successful or not. So again, transseismic approach, we're going to keep harping on that again and again. Now, this basically will tell you how to conceptualize a thyroid nodule in your mind. So it's in 3 dimensions, and you have to basically make sure that you have a plan of different zones. So this is showing you how people plan that. Inferior quadrant, middle, superior. Now, simple question that I have to ask is, why are we looking at the inferior quadrant first? Why is every slide and diagrammatic animation I've showed is that we start here? Anyone have any ideas why we start at the bottom? So you can see exactly, that's exactly right. So if you start zapping up top, you will have so much artifact, you'll never be able to see anything underneath that. So plan that in your mind. Zap the area that you don't want to go back to again, that you don't want to see again. And if you start zapping up here, you won't see anything underneath. So it's very, very important to understand. So different zones. This nodule is 3 different zones, 3 different areas of overlapping. Conceptualize it in your mind as a 3-dimensional structure, and that's how you go. All right, so another option is to give yourself a more visual idea of what you're trying to zap. There's different colleagues of mine who actually even draw on the neck to figure out superior extent of the nodule, middle, lower part. I'm going to start here, and we'll look at that tomorrow, because if it's a really long or big nodule and you don't plan it out properly, then you have to take out this 18 gauge antenna and reinsert in 3 different areas. It leads to more bleeding and makes the procedure a little longer. So you want to be able to access it from one entry point and be able to get all the parts of it without having to take it out and go back in again here and here. This is a pretty thick antenna. So, you know, when you take it out, it takes about 2-3 minutes just to keep pressure on there. And it causes more edema, more hematoma around the thyroid capsule, more artifact, makes it harder to see. Now, there are certain cases in which there's no other option but to insert here and here, because some nodules start here and go all the way up to the mediastinum. So it's a little hard in those situations. But for most nodules, have a plan in your mind. Figure out where you're going to enter and what you're going to do. So this is a simplistic depiction again. So again, the same concept we're going over again and again, because this is really important to understand. Transseismic, overlapping, moving shot technique. Transseismic, overlapping, moving shot technique. There we go. So as you can see, that you start with the inferior part, get the inferior part, you get the superior part, unit by unit, anterior to posterior, until you feel like you're done. Always during the middle of the ablation, stop, scan, have a look, see what's going on. Have you zapped enough? Is there still viable tissue left that you have not ablated? Because the ultrasound pictures will show you most of the times, because the areas that you've successfully ablated become really hyperechoic, really shiny. So you're like, this is done, that's not done. That looks like exactly what it was like before I started doing this. I'm going to go over to this other quadrant. So this is an idea of who is a candidate and the demographics of nodules. So before I start this, I think it's been about 15 to 20 minutes. I'm going to have any questions about the basics of the RFA technique that we went over in a minute ago. Anyone have any questions?
When you're putting the needle back in the moving shot technique,
Yeah.
And then when you sort of reinsert it, do you put the machine off at any stage, or is the RFA continuously on?
Sure. So no, that's a very important question. So the operator tomorrow, when we do live cases, is sitting there, and you basically ask them to turn it on when you can see where the tip of the needle is. You watch it all the way until you're ready to get to the capsule or closer to the capsule. You do not come out of the capsule. You ask them to stop, and then you advance it back to the area you want to, and then you ask them to turn it on again, and then you withdraw. You got to see it throughout. If you can't see the tip anytime, don't assume you know where it is, always stop. Because turning on the machine and turning it off is the simple act of pressing a button. It's pretty easy to do. So you stop. So basically, you're inside the nodule, you turn it on, you can see the whole thing, you progress outside with the moving shot technique, you see it all the way to where you want to end. Before you exit the capsule, you ask them to stop. You reposition the needle, turn on the machine again, and go back again. But we'll do that a lot today with the phantoms and tomorrow with the patients also. Any other questions about the basics? Anyone online have any questions about the basics? I see some questions popping up. I can't seem to access them from here. I think is there a way of looking at that? No online questions? So that's an excellent question. So absolutely. So you start with 25 to 30 watts. That's typically where I start. And if I'm not seeing the micro bubbling happen, if things are not working, if the impedance is not going up, you up the power to another 5 watts. You go up to 35, then you go up to 40, you go up to 45 if you need to. The bigger the tip of the antenna, the more energy will be needed. So if you're using a 1 centimeter antenna, mentally be prepared. I'm going to probably start at 40 or 45. But this is highly variable on the structure of the nodule you're treating. So the biggest publication on RFA done in the US is the paper my group published about 6 months ago. And we looked very closely. If there was one metric, if there was a metric or a predictor that told us that this is a successful ablation versus it's not. And there was no independent predictor. You don't have the amount of volume energy delivered is not the only thing. Like if I ablated this with 55 watts, this is definitely going to shrink versus 30 watts. So there's no real predictor. Now, there is studies like this from my colleagues in Italy who look at higher energy being delivered as an important predictor of a successful ablation. But if you look at those papers more closely, what they do is they do a lot of vascular ablation. And so they're focused on vascular ablation. So they would see whichever vessel is feeding the nodule. You get close to that vessel. And remember, what does the vessel do? It's basically taking heat away from the place, right? It's taking heat away because blood is flowing. So they really up the power when they get close to the vessel. And you can see venous staining happening when you're doing that. I'm sure you guys see that in your liver procedures also. You can see the veins staining, like they're basically, there's bubbling going on inside the vein. You can stay there with a higher power until the vessel thromboses. That's one other metric which looks at successful ablation. If you can actually zap the vessel with higher energy, you might get more volume reduction. But that's based on the study that the Italians have published and looking at vascular ablation. Our paper, it was 60, 70 cases, is published in the Journal of Endocrinology and Metabolism. We didn't see any predictor. The amount of energy delivered or time, active ablation time, we don't really see any one metric. So the energy can be upped based on what you're seeing on the screen and what the impedance is. That's what you do.
Thank you, sir. So another question is, do you go posterior to anterior and quadrant brain to avoid artifacts?
Posterior to anterior, that's exactly what we were just talking about. Absolutely. To avoid artifact, you go to the inferior part and you withdraw so you can see anything above it. You don't zap at the top because then you won't see anything below it. So that's exactly what we talked about. I'm glad we reinforced that concept again.
So the second question is, how to identify reserved thyroid?
So the person does not have primary hyperparathyroidism, you don't have to worry about it. You're not going to see a normal parathyroid. You don't see normal parathyroid. And so if the person has primary hyperparathyroidism, you might see a lesion. Now, the majority of parathyroids are in about a centimeter below the lower pole of the thyroid. So unless if you really mess it up and you go through the posterior part of the capsule, you're not going to go behind the thyroid. So that's not a real concern. The only time we do RFA for we zap a parathyroid is when we're trying to treat hyperparathyroidism, which is something we do in my clinic. When somebody has an intrathyroidal parathyroid adenoma, and they're being told by the surgeon that to fix this, we're going to take out the right lobe. Intrathyroidal parathyroid adenoma is about 3 to 5% of primary hyperparathyroidism. Most of the time, surgeons cannot express that gland outside, even though you can see the pedicle going inside the thyroid, they can't do it. And in that situation, they say, oh, I'm going to take out the right lobe also. In those situations, if you have RFA available, you can give them the same result. In fact, there's a Chinese study published about 3 months ago, which showed the success rate for primary hyperparathyroidism with RFA is 90 to 95%. Which is similar to surgery. Now, it has to be replicated in the US and other places. And we've done a few parathyroids. We've had good results. Do I want to do parathyroids with RFA? No, it's very complicated. It's difficult because most parathyroids right where the nerve is. Most of them are right where the nerve is. So you have to hydrodissect, you have to inject a bunch of fluid, push them up. There's a video of a parathyroid adenoma ablation. You can look it up on YouTube if you Google my name. That's a video of it that, so it shows the whole procedure. But it's hard. So we don't have to worry about parathyroids getting sacrificed doing this because normal parathyroids are far away from the areas that you're zapping. So to answer that question, don't have to worry about normal parathyroids.
I think the last question is, congratulating on the excellent work, and is asking what's the success rate to develop from deep removal with this technique?
So we're not trying to remove everything. We're going to talk about that. This is not the goal of this procedure. The goal of this procedure to zap a benign nodule is to take care of compressive symptoms. Okay, cosmetic distress. If you have a nodule right here and it's bulging out, and you're a young lady, that's not something you want to carry around with you. It causes distress in your life. If you're having difficulty swallowing, if your voice is changed, if you're coughing repeatedly because of the size of the nodule, those are real symptoms. They are daily detriments. They bother you on a daily basis. Some compressive nodules are so large that you get a positive Pemberton sign. You guys know what a Pemberton sign is. You can basically see the blood being blocked from going back into the heart because the lesion is so big. So you're trying to give them relief. Now, how much volume reduction do you need to give them relief? 30, 40, 45%, most of the time symptoms are gone. You're not trying to zap it and make it go away. You're trying to give them relief, which is really important. And that doesn't require the whole thing to go away. That's not the target. The target is to give them relief. If that was the last question, we're going to move on to the clinical aspects of this. Who needs to get this? What are the indications? What are the demographics? Now, I haven't worked in Pakistan. I left 20 some odd years ago. But I think that the demographics are probably more skewed towards more thyroid disease because we have endemic iodine deficiency. We have more nodules and stuff like that. But population-wise, we're pretty similar. There's 230 million of us, and there's about 350 million in the US. So demographics are close. So I'm going to try to see if I can extrapolate and give you an idea of how big the scope of this problem is. So how many people do have nodules? Well, in the US, on ultrasound, 40% probably. Palpable nodules depends on their age. If you're a 40-year-old woman, your chances of having a thyroid nodule is 30 to 40%. So if you extrapolate that, that's millions of people, millions of people. Now, if you look at the natural history of these nodules, and this is an Italian study, there's smaller US studies, but in the Italian study, you can see that, I do with my pointer, here we go. So about 11% are going to continue to grow. I think it's probably around 20 or 25 in the US, probably around that. So if you have a nodule in millions of people, 20% of them or 200,000 out of 1 million will have nodules that are going to continue to grow and at some point in time start giving you symptoms. It's a pretty big number. You extrapolate that to our population, you're looking at millions of people who have this problem. Most of them stay stable. Some of them shrink. The ones that shrink typically are, colloid type nodules with cystic solid component, different things. Hemorrhage can happen. They can necrose. Why do we do so much thyroidectomy? Well, in the US, we do close to 165,000 thyroidectomies every year. Can anyone guess how many of them are cancer out of 165,000 every year? Throw out any number. There's no wrong answers. What was that? 20%? 1% is cancer? No, the cancer is pretty common. Thyroid cancer is very common. So 100,000 out of those 165,000 surgeries approximately are for benign disease. So majority of surgery that's being carried out in the US is for benign disease. Now, I think it's probably the same here also. Majority of surgery is being done for benign disease. The reason we do this is obviously, I'm an endocrinologist. I think surgeons are like hammers. To them, everything is a nail. So they'll do surgery on everything. Also, they don't use genetic technology for biopsy results to interpret them. 15 to 20% of biopsy results are going to come back as indeterminate. They'll tell the patient, yeah, there's a 20% chance of cancer. Let's just take it out. That's not really the way we do things anymore. You got to do, you can do an RNA sequencing, you can do DNA mutation profile, you can take majority of those patients out of the surgical pool. So you should not do surgery for benign nodules. That's what I'm trying to say. This is what you should do. This is what we are doing. And this is what we're going to do all over the world. Why do we want to do this? Well, what is the complication rate of surgery? Does anyone know? In the US with high volume surgeons, High volume surgeon meaning somebody who does more than 30 a year. These guys are supposed to be really good. Even in their hands, it's between 6 to 7%. Nerve injury, permanent hypoparathyroidism, scar, bleeding, hematoma, hospitalization, different things happen. So surgery is fraught with complications, even in the best hands. RFA is not anywhere close to that ballpark in terms of its risk. It's much safer. So thyroidectomy should be avoided for benign disease. In fact, I think it should not be done for most of those cases. And we're going to pick apart the ones which should still go to surgery and which should still come to you guys. I'm going to talk about that in a minute. All right. So now we don't have guidelines for radiofrequency ablation in the US yet. So I'm one of the founding members of the North American Society of Interventional Endocrinology. We have a group which is working on putting out a statement. The reason we don't have a statement of our own is because we haven't done enough of a volume. Our center has done more than 200, and in our association, I think we've probably done close to 900 to 1,000. So we're working on those guidelines. But I'm going to talk about these guidelines that different other countries have. Now, they also have their own economic pressures and economic realities. Some of them have nationalized healthcare systems, so the recommendations are colored by those economic realities. But we'll go over those and keep them in your mind and see what you think. Now, I like to follow these guidelines the most. The Korean guidelines, which are back here, 2017, because they have the most amount of published data, in my opinion, and it's just a lot more relatable for me. So let's go with the Korean guidelines. Symptomatic or cosmetic problem? Absolutely. Now, what is a cosmetic problem and what is a symptomatic problem? That's very subjective. You have to talk to your patients, honestly. If you ask them, does this bother you? Yeah, most of the time, no. Right? When you ask them, like when you lie down on your left side, do you feel comfortable? No, I don't actually. Right? Well, that's a problem. Do you have any hobbies? Yeah, I like to sing. Is your singing voice being affected by this? Absolutely. I have a hard time projecting my voice. All right. Yeah, that's another problem. Do you have chronic cough all the time? I could be acid reflux, but if you have chronic cough, and this is a huge big thing, really pushing on your trachea, 2 + 2 is typically 4. So it's probably this. So these are the questions you ask. Now, how big does a nodule have to be to give you symptoms? Now, I've been doing this for more than 20 years. Just thyroid, only seeing 20, 25, 30 nodules day in, day out. It is highly variable. There are some people who are bothered by a 2-centimeter volume nodule, and there are others who are oblivious to a 7-centimeter volume nodule. So it's different. So don't have a preconceived idea in your mind that what is and what is not compressive. That's really important to understand. Cosmetic distress, in my opinion, is very important. Remember, this is a female disease. It's a women's disease. Men get nodules and goiters too, but majority of the time, it's women who are affected by this. And their association or idea of cosmetic distress is very different than ours. If they feel that this is bothering them on a daily basis, then that's an important thing to me also. If this is bothering you, then yeah, it's an important thing. I got to do something about it. So cosmetic distress is an individual thing, and you have to listen to them. Non-functioning thyroid nodules, yeah, absolutely. Cystic nodules, they're going with ethanol. Now, it's really important to understand that pure cystic nodules are extremely rare. So basically, majority of the time you will see solid cystic nodules, and for that, RFA does way better than ethanol ablation. Do you guys do ethanol for thyroid cysts here? No. So I do those maybe 5 times a year. So think about it. Like if I'm doing hundreds of different thyroid ultrasounds, and I can only do 3 or 4 ethanols a year, that can tell you how many pure cysts you see. They're very rare, very uncommon. Most of the times when you see a pure cyst and you aspirate it, you'll see a big solid component. Until you have ablated that solid component with RFA, ethanol alone is not going to give you those results. So, cystic, completely cystic ethanol, otherwise RFA is much better. Toxic nodules. Now, our recommendation, our society's position in the US, based on our publication and our experiences, if you have an autonomously functioning thyroid nodule that is less than 12 cc's in volume, if you have a toxic nodule less than 12 cc in volume, this is first line. You should always do this. And we have already recommended that in our paper and in our upcoming guidelines. Why do we say that? Well, for toxic nodule, you can do surgery. You can take out the whole side. Remember, you can't just take the nodule out. A good surgeon is going to take out half a thyroid. If you have a toxic nodule on the right side, you take out half a thyroid. What are the odds that that person is going to be hypothyroid in 5 years? Any numbers?
It's 40%.
There you go. It's a big number. Let's say you have a 25-year-old lady who's going to get pregnant later on. Do you want them to be on thyroid medication the rest of their lives? That's not fair. What about radioactive iodine? How successful is that in zapping these? You guys in radiology, you know the numbers? Failure rate in that is very high, actually, by the way. 20 to 30% of those fail. You can also exacerbate or induce Graves' disease, up to 4% of people, by giving them radioactive iodine. And hypothyroidism, because radiation radiates. It's going to cause hypothyroidism 5-10 years down, pretty similar to surgery. So all the current guidelines, current first-line modalities for toxic nodules are fraught with long-term complications. Now, this doesn't have 30-year follow-up with radiofrequency ablation, but we have 5-year studies, 4-year studies. If you ablate a toxic nodule that is less than 10 cc's in volume, your success rate is 100%. I'm going to say that again. If you have a toxic nodule and you zap it and it's less than 10 cc's and you do a good job, 100% of the time you will get the nodule to basically stop causing TSH suppression. And the complication rate of it causing hypothyroidism is like 0.0 something percent. It's not going to cause hypothyroidism. It's only going to zap the toxic nodule. So for toxic nodule, this is first line, as long as it's not really huge. So what is really huge? Well, if you look at our study and different papers like that, when you start going up above 15 cc's, 16 cc's, the bigger it is, the harder it is to zap all of it. You know, the artifact and stuff we're talking about, there'll be areas that you miss because you can't see it all. And the success rate of that after 15, 16, 20 cc's comes down to 80%, 70%. The bigger it is, the success rate starts to drop. So in those nodules, if they're still adamantly opposed to surgery, you have to tell them this is going to take 2 sessions. I'm going to do 1, your levels will drop by 50%. You come back 6 months later, I'll do a second one. Now, that is very expensive in Europe. And why is it expensive in Europe? Well, in Europe, the funny thing is, you know, because I've been to Italy and for lectures and talked to those people. Surgery over there is pretty similar in cost to RFA. So they're like, why would I do 2 RFAs when I can fix a problem with 1 surgeon? It's similar to other nationalized healthcare systems also. That's why some of these guidelines are skewed that way. But in the US, thyroid surgery is $20,000. That's a really big number, give or take. It's $20,000 for thyroidectomy. And RFA is anywhere between $5,000 to $7,000. And the price for RFA is going to continue to drop. Now, why is it going to continue to drop? Because, you know, we can make these things cheaper if we make higher volumes. So I think things will change. But surgery price is not going to drop. It's never, the price of medical procedures in the US has never dropped. Now, is this going to become a viable technology in Pakistan? You guys will be the judge, but I think so. I think that these antennas will become more widespread and we'll be able to make them for cheaper, make better antennas. It's just a matter of time. And think about it from 15, 20 years ago. I remember first plasma TVs. I wanted to go buy one. I just finished my fellowship. It was like $7,000. Now you can get a HD TV 15 years later for a couple of hundred. So I think prices will drop. As of now, surgery in the US is around 20,000. RFA is less than 70% of the price. So you can do 2 surgeries if you want, or 2 RFAs if you wanted to for a large toxic nodule. But for nodules less than 12 cc's in volume, strictly medically speaking, not looking at the finances of this, RFA is superior, no doubt. And so that's why our society guidelines and statements, which will come out in the next 6-7 months, once we publish the 600 or 700 patients that we have, our recommendation most likely is going to be in the US, toxic nodule, first line treatment. So as long as the nodule is not too large. Let's walk down this schematic some more. Multinodular goiters, they don't do it. Again, that depends. Right? So here's what it depends on. If you have a multinodular goiter on the right side, and there's one nodule that's 10 cc's, and the other nodules are 2 or 1 cc's each, you can technically go after the big nodule that's causing the problem. So I don't wholeheartedly agree with this, but the rationale behind this is that you can fix the problem with surgery. With RFA, it'll take so many procedures to zap all the nodules. We don't have to zap all the nodules. Our goal again is to give you symptom relief, and you can go after the big one. So this still is again subject to interpretation. 2 benign biopsy results are necessary. Now, this is what they're saying. But if you look at the data more carefully, there's an Italian study which looked at, I think, 3 to 5 year follow-up. And the risk of cancer after 1 benign biopsy was around 2.5%, give or take. And the risk of cancer or false negative after one benign biopsy was pretty similar. So it all depends on the person performing the biopsy. But for right now in the US, we like to have 2 benign biopsies for a thyroid nodule that looks semi-suspicious. For a really low risk lesion, a spongiform nodule with grade 0, grade 1 Doppler flow, 1 biopsy is enough. For a toxic nodule, 1 biopsy is enough. So it depends on the type of nodule you're looking at. Absolute contraindications. Nobody pregnant, nobody with a pacemaker. Now, anyone have any idea why a pacemaker we can't do it? Anyone know?
Normally you have the grounding packs.
There you go. Yep, exactly. There you go. That's it. Yeah, it'll basically fry the circuitry inside it. You don't want electrical current going from here to there. And so pacemaker is a big no-no. We've done it with people with these pumps and stuff that are further down, like pain pumps and other types of implanted devices, because we put the grounding pads up on the chest, so the circuit is smaller. So we do that. But for metallic implants like titanium in the neck and stuff, you can go ahead and do it. I've talked to a lot of these pain anesthesiologists who do RFAs of nerves in the back. They're like, nothing bad ever happens. It's fine. You can go ahead and do it. So I'm going to do it for those. Pregnancy, no, can't do it. Now, and a caveat is that there are monopolar electrodes that are not available in the US. They might be available in China and here. I'm not sure. That's something we got to look at. If you have a monopolar electrode, then you can still go in after it, because then you don't need grounding pads. The whole circuit is inside there. I've never used one, by the way. So I've never used a monopolar electrode. All right, let's go over to the next slide. What happened? We stuck? Come on. No? We seem to be stuck. Oh, here we go. Yeah, perfect. Thank you. All right, so pre-RFA evaluation. This is something we're going to do, hopefully, with our candidate patients today. You do an ultrasound. You do an ultrasound because you need to figure out how big is this. You need to know the volume, where it's situated. Start planning in your mind. Okay, this is what it looks like. This is how I'm going to access this. These are the potential pitfalls and complications I can run into. You get the symptom score because you need to know how bad the symptoms are. And there are some verbal symptom scores you can look at online. There's a cosmetic score that goes to from 0 to 4, and there's a symptom score that goes from 0 to 10, and these are available online. But you got to have an idea of where they ranked on that symptom score. So when they come back 6 months later, you can figure out how much improvement did they had. Lab tests, very important. Get their coags, CBC, test thyroid levels. Most importantly, test thyroid antibodies. And why do we want to do that? Remember, RFA is not going to cause hypothyroidism. It is not going to cause hypothyroidism. That's extremely rare, less than 0.03%. But Hashimoto's thyroiditis will cause hypothyroidism, and Hashimoto's thyroiditis is extremely common. And you can have normal thyroid levels, but if the antibodies are high before you do the procedure, you can tell the patient, listen, you have this autoimmune thyroiditis. This will probably give you hypothyroidism 5 or 6 years down the line. It's not the RFA that's going to do it. So it's an important thing to do. Calcitonin, you can do it if you're worried about medullary cancer. I don't. Vocal cord evaluation, I only do that for patients who have had surgery in their neck already. So you're worried about the possibility of unilateral paralysis in the vocal cord. Do you guys look at the vocal cords when you're doing ultrasounds at all? Okay, so you can actually use the transducer. You put it up here and make a window into the voice box and make them hum, and you can see the true vocal cords vibrate. And it's about 97 to 98% sensitive and specific. It's very, very good. You see both cords moving, that's enough. You're like, yeah, this is fine. You had surgery there, but your cords are fine. So if somebody's had surgery or they come to you with already a hoarse voice, even with a benign nodule, have a look at their vocal cords. Now, why is that important? Well, if this side is paralyzed and the nodule on the other side, and you go there, you knock out that nerve, you're going to be calling head and neck surgery to come to a trach. You don't want to ever get in that situation. So always be worried about the vocal cords. And also, it's a really important concept to understand with that is, that's why we don't treat nodules on both sides in one day, in one session. Because you can technically damage both nerves. So always, patients are going to say, I have one nodule here, one here, I want to get them done both the same day. Sorry, can't do that. You do one side at a time. So what if we damage both nerves? That's a big problem. So we never do that. Toxic nodules, obviously, you do an uptake and scan to confirm where it is. You don't have to do it afterwards, but you got to do it before that. Post-RFA evaluation, as I said, the Koreans will do a scan after that. I don't think that's necessary. think thyroid function tests are the most important barometer of success. If your thyroid TSH went from 0.01 to 2 6 months after the procedure, you're successful. You don't have to do a scan to confirm that. You already know that. So why do we do initial treatment? Well, if symptoms don't improve, if volume reduction is less than 50%, nodule is starting to regrow, you can do a second session. Again, that's a case-by-case discussion, but those are typical reasons. Now, how many people do I retreat? A few, and those are the ones who have really big nodules to begin with, and they didn't have significant reductions. I'm talking about people with 60 cc volume nodules, 70 cc nodules, goiter, they go from here to here. Obviously, I can't zap it all in one session. So I tell them I'll zap the top part, wait for it to thrombose or get reabsorbed. It'll pull up the part that's lower. It'll come up in second session. I'll go after the lower parts. You can plan it out like that if somebody is still adamantly opposed to surgery. But if you see a lesion that is so big or really big and the patient wants immediate relief, you can have a discussion. And like, I think you should get surgery because one session will fix the whole problem. But if you're still scared of surgery, you want this, then do understand it's going to take more than one session. So recurrent thyroid cancer, we do a lot of that. Here's the Korean guidelines. I do probably 1 or 2 of these a month because thyroid cancer is extremely common. Right now in the US, I think in women, it's the 4th most common cancer. Mortality rate still is very low, but we already know that. Mortality rate is 1% or less. But recurrence is the problem with thyroid cancer. Recurrence is very common for all stages of thyroid cancer. It's somewhere between 30 and 40%. So 30 and 40% of patients with thyroid cancer will have lymph node metastasis or recurrences in the neck. And most of these are actually persistent disease rather than recurrence, but we'll call it recurrence for the sake of this discussion. And it'll come back in lymph nodes. So if you've done 2 or 3 surgeries, the surgeon can't really go back in again. There's a lot of scar tissue over there. And it's harder and harder for them to keep going back in. And in these situations, RFA is another viable option. You can basically zap 2 or 3 or 4 lesions as long as they're not too big, as long as the lymph nodes are around this size, again, for the same reasons. We can't zap a really big nodule and kill it completely, but you can kill cancer less than that. How successful is this? Very successful, according to Korean studies. Now, we're working on a paper right now. We should be able to publish. We had an abstract with the American Thyroid Association about 6 months ago from our smaller data set. But we have about 16 or 17 lesions that we're going to publish very closely. Very soon. And most of these lesions go away. Most of these lymph nodes go away completely. They disappear. Up to 93 to 95% of them with one session. So this is very effective. Now, the problem with this is that in the neck, when recurrences happen, it's just typically not just 2 or 3 lymph nodes. There are other lymph nodes involved too that are smaller that you can't see. So neck dissection is the best way of curing cancer. But if you've had 3 or 4 surgeries, you're not going to go back for another surgery. This is what you do. This really works for that. It's very successful. It's very effective. If you have a thyroglobulin level of 3 or 4 and there's only one lymph node that's 1 or 2 centimeters, you can go after it and get really good results. And once the study is published in the next few months, I'll be happy to share it. But there are Korean studies like this, which show 93 to 95% success rate at completely obliterating the malignant lymph node. Again, same things. You do a very good ultrasound. Make sure you know how many lymph nodes are involved. You can do a special CT that people use in Korea for this to make sure there are no other lymph nodes that you're not seeing. If you have like 6 or 7 others in the superior mediastinum or level 5, then there's no point in doing RFA. They still need a dissection. But if a enhanced CT in the neck shows, yeah, there's only 1 or 2 lymph nodes, yeah, you're going to do RFA for that, and it'll be very successful. That's an important thing to do. PET CT not necessary. Again, post RFA evaluation, we don't do this. We follow the ultrasound. We follow the thyroglobulin levels. That's what we do typically after the ablation. And as I said, in 90% or above of these patients, when they come back 6 months later, the malignant lymph node is not visible anymore. It's gone. It just basically goes away. Pain control. For this technique and for RFA, you can do it under local anesthesia. You can do that under local anesthesia. However, my recommendation is that when you guys are learning, if you have the ability to get some help with conscious sedation, it makes life much easier. You can spend more time ablating the nodule because you're not worried about the patient getting upset or uncomfortable. So you're not trying to rush yourself. You have enough time. Critical structures, D5W hydrodissection. I'm going to talk about that in the next presentation. I'll show you how you can create a cushion of cold D5W between the lesion that you're trying to protect and the lesion you're trying to, the structure you're trying to protect and the structure you're trying to zap. Now, why do we use D5W, not normal saline? It says it right here. It's non-ionic. If you're running electrical current through the system and you have normal saline, there's ions in it, and you don't want to use that. D5W doesn't have ions in it, so you can use it. Smaller lesions, obviously smaller tip. Lymph nodes will be small, so 0.5 centimeter tip is perfectly fine, and that's the smallest one we have. In Korea, they have a 0.25 centimeter active tip also, so there's smaller ones that are available over there, and I'm pretty sure they could be made available here also if necessary, if needed. So this has been part of the guidelines for a long, long time. American Association of Clinical Endocrinology said that you should consider laser radiofrequency ablation for benign nodules. And this is a long time ago, back in 2016. Recently, we had a webinar of our own, and Roberta Volcavi, who's a good friend of mine, was also on that. And so they've been doing it for a long, long time. Most of the other authors were American, except for Professor Pupini. And so at that time, this didn't really get as much traction, but now it's very, very routine. When I first started doing it, other than a few cases done at the Mayo Clinic, no endocrinologist ever done it. Now I think we've trained at our center close to about 25 physicians to do it. There's maybe 100 centers doing it in the US, but the Koreans and Germans and the Italians have been doing it for close 15 to 20 years. So this is mainstream. The American Thyroid Association guidelines for thyroid cancer and thyroid nodules, published in 2015, also say that you can use RFA for recurrent disease. So it was part of the guidelines even back then. Right, so same thing, going over it again and again, major, minor indications, contraindications. Symptomatic nodules, clinical problems, nodules more than 2 centimeters that continue to grow. That's a good cutoff to have 2 centimeters for compression. Not for toxic nodules though, that's a whole different thing. And contraindication, complete cysts, so don't do it. Follicular neoplasm, yeah, if you don't know it's benign, don't touch it. And primary thyroid cancer. Now, that's actually controversial. Primary thyroid cancer is being done with RFA. There was a recent editorial in Clinical Thyroidology that looked at a Chinese study which compared microcancer treatment with hemithyroidectomy versus RFA. And the result was extremely similar. There was no difference. So for cancers that are papillary thyroid cancer around 1 centimeter or less, and you can do this instead of surgery. It works really well. But there's some nuances to that. We can discuss it if that's something to talk about, especially if you have the ability to do genetic sequencing on that before you do it. Make sure they don't have some high-grade mutations. All those things really are helpful, but you can do it for small cancers. It does work. Same thing being repeated again. And we're going to go over the anatomy. So I'm going to take a little break here and answer any questions before we start on the anatomy. Anyone have any questions? All right, that's an important question. So 6 weeks is the soonest I have him come back. The reason is the day after RFA or the 2 days after RFA, there's going to be some edema, there's hematoma, there's some swelling. Doing an ultrasound at that point in time tells me nothing. The reason we don't have to have him come in 3 or 4 days afterwards, the complications are so infrequent. They're so infrequent. Most complications happen during the procedure that you don't have to have him come 3 or 4 days later. When we go over the complications, you realize most voice changes or injury to the recurrent laryngeal nerve will happen right there. And you got to act right there to fix it. And I'm going to go over that also at the end, how to fix it. But they're not going to typically develop recurrent laryngeal nerve injury or hoarseness 5 days later or 6 days later. There are rare complications like nodule rupture that can happen delayed 3 to 4 weeks or 6 weeks, but those are really, really uncommon. I mean, I think there've been like 20 or 30 reported cases out of thousands of people. So we haven't come back in 6 weeks because I'm not too worried about them. I don't think anything bad will happen. At 6 weeks to 2 months, I'll do my first ultrasound. Majority of the volume reduction will be in the first few months. The first 6 weeks ultrasound is really, really illustrative of how successful you're going to get. So if you've had 30, 40, 50% reduction in the first 2 months, you already know it's gonna do really well. Volume of the nodule after one successful treatment will continue to decline slowly for up to 3 years, sometimes up to 4 years. It continues to shrink. I'm seeing some of my follow-ups that I did my first session back in 2018 come back in 2021, and they continue to shrink. Now regrowth can happen too, but regrowth is between 4 to 8% typically. 90% plus of the nodule will continue to shrink slowly and gradually. So 6 weeks first, then 6 months later. And if the trend is good, until them come back in a year. Just do an ultrasound after that. The caveat is, they come back 6 months later and there's regrowth, then you have a problem. You got to biopsy it again, make sure it's not cancer that you missed. And if there's no cancer, zap them again. Do another procedure if it's starting to regrow. Regrowth will happen and you won't understand why it's happening. There's no clear predictive model why some nodules regrow. Benign nodules, why some of them regrow. We don't know. Sometimes it happens. So you guys know the anatomy very well. I'm briefly going to go over it again. You can see all the... Sorry. Yeah, so that's exactly what we were talking about a little while ago. If you have like a really large nodule and the person wants it gone right away, surgery is going to work. Now, 30, 40, 60 cc's, you use your judgment. If it's 40 cc's and their symptoms are mild, you can tell them, I can do one session. I can get you down to, let's say, 20 cc's in volume. And if your symptoms go away, that's good enough. Fair enough. So that's something you could try. But if it's a 100 cc volume nodule and they want the problem solved right away and they're open to surgery, yeah, they should go for surgery. So that's a little subjective. But really large nodules are not going to go away with one session. Really large nodules, 40, 50 cc's, are not going to go away. If you're trying to shrink them a little bit to give them some relief, it's a 70-year-old lady who's having problems every day. They're not going to go for surgery. You can do one session. So there's no absolute contraindication. If a 75-year-old lady came to me and said, I have AFib, I'm on Coumadin, I have heart failure, and I have this thing that makes it hard for me to swallow, and this is 60 cc's, what are you going to do? I'll do RFA. I'm going to give you some relief. I'm not going to send you to surgery. So there's no absolute, but yeah, the bigger nodules are not going to go away with one session. So anatomy, you can see the sternohyoid, the sternocleidomastoid. You can see the longus colli muscle. This is at the C7 level. You can see the spinous process of the C7, this shiny thing right here. Important things to understand are the nerves here, here, and here. We're going to go over those. Those are the things you want to avoid. Those are the things you don't want to injure. So there's 3 major nerve injuries that happen with RFA. Sorry. Okay. So use it. Okay. Right. So use the mouse. All right. So here we go. See if I can do that. Oh, okay. So yeah. So the 3 major injuries, 3 types of nerve injuries that are going to happen. The most common is the recurrent laryngeal nerve. So basically, hoarseness of voice will happen right there and then while you're doing the procedure. So tomorrow, if we hopefully do a few procedures, you'll watch and see that every 2 minutes, we will ask the patient a preconceived question that they have to answer, like their address or their name or some other phrase, and they keep repeating that every 1 or 2 minutes. If any of the treating physicians in the room feel like, hey, this is not the same voice, you stop right there, because that's recurrent laryngeal nerve injury. And then I'm going to show you what you do to redress that injury right there and there. But hoarseness of voice is the first thing that you're going to see. Vagus nerve injuries are also possible. They do happen. And arrhythmia, dysphagia, dyspnea, hiccups, nausea, all of that stuff. Vagus nerve injury can be catastrophic. It can be really, really problematic for the patients. There are patients who've had vagus nerve injuries and thyroidectomies who have, permanent G tubes because they just keep having nausea. Renal denervation can happen. It's really problematic, so you have to be careful. Sympathetic trunk injury, you'll see, basically conjunctival injection right away. You'll see ptosis, meiosis, the whole Horner syndrome thing. This is uncommon though. Most common nerve injury is recurrent laryngeal nerve injury. That's the thing that you see. So we already know the course. It goes underneath the innominate and the subclavian. It's a little more lateral here on the left side. On the right side, there are some anatomical variations. You do have to know that there are about anywhere between 0.3 to 0.5 or even 0.7% of patients who have a non-recurrent laryngeal nerve. So it goes straight off of the vagus trunk. And so sometimes I think the injuries can happen because of anatomical variations. You don't know where the recurrent laryngeal nerve really is, but that's less common. The mechanism of recurrent laryngeal nerve injury is still not clear. It could be from compression of a hematoma that is pressing on the nerve. It could be leakage of hot liquid and gases underneath the thyroid that goes and irritates the nerve. It could be direct thermal injury because you somehow got so close to it that it got heated up. So the different things can happen. So you're not going to see it, but you know where it is. So you have to be, well, typically you know where it is. So you have to avoid it. And that's why we do the transseismic approach. And we always have to know where the tip of the needle is. Anytime you're not comfortable, you don't know where it is, you stop. You wait until you have a good visual. You have to be very comfortable where the needle is. And then you start the ablation procedure. That's when you ask them to turn the generator on. Vagus nerve. Now, how do you avoid it? Vagus nerve injury? It's pretty simple. Just look for it. Now, can you see the vagus nerve? Absolutely. How often? 100% of the times. You can always see the vagus nerve. I have not had one ablation where I have not been able to see the vagus nerve. But you got to see where it is and track it. A simple rule of thumb is rule of 30s. 30% of them will be inferior medial. So I'm going to use the mouse here. 30% can be here. 30% are going to be lateral. 30% can be superior, roughly. So this is a good location for it. But you have to understand big nodules can distort the whole structure of this. They can push up the vagus to a more medial position as you go up because it's basically rotating everything up. I'm going to give you an illustration of that. And this is a real patient, obviously. Here you go. So look at this. This person's vagus nerve in the inferior part of the nodule is in the lateral position. As the nodule distorts the neck anatomy, you see it moving into a medial position. Now, if you were zapping this here, assuming that, hey, the nerve is somewhere else, you could injure the vagus nerve. So you always have to follow it throughout its course. And always keep a 2 millimeter distance from the edge of the capsule anyway, if not more. But that's how you avoid injury to the vagus nerve. Now, how do you see it? Again, it's going to be right here in this carotid sheath, this bundle. You can see it. And you can do on the longitudinal, you'll see this spiculated, long, shiny type thing. Tomorrow I'll show you, you can see it. So it's not that hard to see. Sympathetic ganglion, you'll see it in about 40-something% of patients. And in some people, it can be very close to the thyroid capsule. Like this is an example of a central sympathetic ganglion. Now, luckily, I've never run into something this close to the thyroid. And what if you zap this? You could do that. So 41% are visualized, just like that. This is the central sympathetic ganglion. And this is what a nerve will look like on the longitudinal. It's spiculated, shiny, long structure. Vascular structure, not that important. It's really hard to figure it out when you're doing the ablation, but typically this is schematic, superior, inferior thyroid arteries and veins. So. Esophagus and trachea, you know where it is, you know how to avoid it. There has been a case in the US of tracheal perforation during RFA. It lead to pneumothorax and required tracheostomy and then end-to-end anastomosis. So bad things can happen. You have to be careful. Tracheal perforation is uncommon, but it has been reported already in the US. So we're going to go over the key techniques. I'm going to stop here. So we've basically covered the physics, the indications, and the technique. And so this is reinforcing the technique again. Lidocaine injection, which we're going to go over now, hydrodissection, transismic approach, moving shot technique. Same concepts again and again. Overwrapping, and we plan it out, moving shot technique. I'm going to stop for 1 minute if there's any questions, and we'll move on to the next. Am I good on time? We're doing okay?
Yeah.
We're doing okay. All right. Okay. All right.
How long do you wait if you are going to treat a nodule twice or you're treating 2 sides?
6 months at least. 6 months at least. That's 6 months. Majority of the volume reduction you can predict, like, all right, this is the most I'm going to get out of this. Now, as I said a minute ago, that it'll continue to shrink for years, but majority of the reduction will happen by that time. And so if it's not satisfactory at that point in time, you can basically project and say, this is going to need another treatment. So that's what we do. So lidocaine. As I said, this can be done under local. I do it under local, but in some patients we use conscious sedation, which is a little bit of Versed, just to keep the patient calm and to give us some more time to go ahead and do it. But this can be done with just lidocaine. And this is different lidocaine compared to what you use for biopsies and stuff. So you have to find the pretracheal fascia, and you have to basically do hydrodissection with lidocaine in that area. Most of the pain receptors are right here, right? Between the capsule and the thyroid. The thyroid parenchyma doesn't have pain receptors. Pain receptors are here. So if you can lift up the pretracheal fascia and basically inject between 5 to 7 cc's, not more than that, of lidocaine, because lidocaine toxicity is another problem you want to ever get into. So 5 to 7 cc's, you can hydrodissect that area. It'll basically numb up the pain receptors to an extent that you can comfortably do the RFA. I guess in the beginning, if you can do conscious sedation until you're better at the technique, you get faster. It's another option, but you can do it like this. Smaller nodule, let's say it's a 3 cc nodule. Yeah, I'll do just lidocaine, just get it done. Because it's not going to take that long. Okay. So this is hydrodissection for critical structure. And this is real case. So you can see here, the vagus nerve. You can see a metastatic lymph node. Now, you want to kill this and you want to protect this. And how do you do that? Well, you get a 25 or 21 gauge needle and you do an island technique. You basically inject enough cold D5W around it that you have a buffer. Now, the nerve is a little further behind it and the needle tip is right here. You can inject some more fluid. You can come in through here and zap the hell out of it. That's hydrodissection for a critical structure. I'm going to show you other examples of hydrodissection in the method that we do to reverse recurrent laryngeal nerve injury. And if you guys, I mean, that's available on YouTube if you want to look at my parathyroid case, which shows how you lift up the parathyroid so you can protect the nerve. So that's the basic concept of hydrodissection. It's not hard. It can easily be done. You just have to be a little patient, watch the needle go into the area you want it to, inject fluid carefully. How much fluid can you inject into the neck? Well, lymphatics actually are really, really effective at taking care of the fluid in the neck. So 20, 30, 40 cc's gets reabsorbed pretty fast. So you don't have to worry about it. Professor Baek in Korea has done up to 200 to 300 cc's for recurrent laryngeal nerve injuries in attempts to cool down the nerve. It's fine. Water gets reabsorbed. So lymphatics take care of it. Again, same concept, not to belabor the point, transisthmic only. Do not go transverse. This is a interesting schematic of how some doctors plan their RF ablation. So what this is showing is that this is a long nodule. Here's the image, right? The CT image. And so if you go 2/3 of the way up where the green mark is, you can technically reach the top and the bottom part of the nodule. So that's one way of planning it. Some people mark it, medial edge, lateral edge, this is where I'm going to go, this is where I'm going to get to. I don't, but this gives you an example of how you plan it. And the way you plan it is have a plan before they come for that treatment, because you've done the ultrasound in your mind, you know what you're going to do. And before the procedure, put all your preconceived ideas out of your mind, look at it again from the head end of the bed. Like, yeah, this is it. It starts here. If I enter here, I can hit all these areas. That's what you do. But sometimes you need 2 insertions. It happens even now, even after having done more than 200 cases. Sometimes they're like, yeah, this is not going to work. Take it out, wait 5 minutes, compress, go back in again. But as I said, you do that, there's more hematoma. It's a longer procedure, more patient discomfort. So again, moving short technique, very, very important. Keep that in mind. Never leave the antenna in the same place. Keep it moving. So another thing to understand is that the antenna will stop delivering energy if you've bladed the area pretty successfully, because the impedance will go up and the machine has this cutoff, and the energy you'll see will stop from 40 watts down to like 12 or 11 or 14. It won't really deliver energy if you have really high impedance in the area that you've already ablated, but you want to keep it moving. So again, this is another visualization of the moving short technique. Again, same concept again and again until we feel comfortable with it. Here we go. Patient swallows. You can't see the antenna. Stop for a minute and then restart and then withdraw. Here you go. Keep it going until you do all the quadrants that you have to do. Complications. We're going to go over the last part of this. Before complications, any questions about the technique so far? Any questions? No?
Yeah. First question. Have you encountered any allergies to lidocaine?
I have not. Not while doing RFA. Yes, there's patients who come in and tell me I'm allergic to lidocaine and I don't use it. So do you use bupivacaine or some other type? I don't know. But I've never had this encountered in the RFA population so far.
Do you use
No, without. No.
Okay, another question from one of our patient here. He's asking if a person has an aggressive form of thyroid fever or cancer, how much time is going to buy choosing surgically, if he gets it surgically, or if he gets it RFA?
So you're talking about primary cancer?
Primary.
Yeah, I would not do RFA for that. This is not going to do anything. Don't do RFA. For palliation, I've used it for recurrences. But if you have primary cancer like anaplastic and stuff, there's no evidence that that's going to help in one way or the other that I know of. Anaplastic or poorly differentiated cancer, it's either surgery or targeted chemotherapy or other things. If somebody asks me for palliation, I've done that for medullary cancers and other cancers where there's nothing else that's working and there's a big mass about to invade the aerodigestive tract. You can slow it down by doing RFA, but does that have long-term outcomes data? I'm not aware of that. Yeah. So the answer is like, I don't know.
Do you give any instructions to the patient how to swallow really?
No, they can do whatever they want. They're going to be there for an hour. They have to be comfortable, so they let you do your job. They can swallow. That's okay. The antenna is going to be in there for an hour. The active ablation time is typically about 5 or 6 minutes. That's important to understand. The antenna is there for 45 minutes to an hour. You're moving it around. But the active ablation time is 5 minutes, 6 minutes, 7 minutes. So you can't have them not swallow for an hour. They're going to swallow. That's okay. If they swallow while you're doing it, turn the generator off, wait, and then refine where the antenna is, start again. But if you're very comfortable about where it is, and if you lose visual for a minute or two, that's not a big deal. You're not moving it, right? You know where you are. They moved, you lost the visual for a minute. You find it again. You keep the ablation going. But if you can't see it, then by all means, turn off the generator. No, I don't. So the voice, you got to have the voice, right? So the most amount of sedation I'm going to give is so that they're comfortable, but I can talk to them. Because I have to talk to them every 2 minutes to ascertain their voice. If you put them to sleep, you can't ascertain the voice. That's the main complication you're trying to avoid. So never, no deep sedation, ever. In fact, just local only for most nodules. Conscious sedation when you're first starting, or you're not comfortable, or the patient has really large nodules, it's going to take a long time. You can use that, but to the point where they can talk to you. And they're coherent, and you can ascertain their voice. Versed is what we use much faster, but that's a question for the anesthesiologist. Yeah, you could use probably midazolam, Versed, same thing. Yeah, so short-acting benzodiazepines, rapid metabolism. Some patients who were in our practice who have, let's say, alcohol abuse problem in the US, they metabolize these benzodiazepines really fast. They have the cytochrome P450 revved up. So in those people will use some propofol sometimes. But again, their voice has to be maintained. That's the anesthesiologist's job to keep them coherent so you can listen to their voice. Okay, so talk about the complications. So now, in Korea, when this technique was started in 2002, 2009, there were no good standards of what the best practice is. Different institutions were doing it, some with not a lot of experience. Now, this is one of the biggest multi-center studies. Again, our good friend and inspiration, Professor Baek, was looking at all these studies. And their numbers are very different from the Italian numbers I'm going to show you. But what they showed was that more than 1,400 patients in 13 different institutions with variable level of expertise with RFA. This is what they found. Okay. So we keep talking about the nerve, right? So out of these 1,400 patients, we had about 15 who had voice change. So what is the number? 1 out of every 100 will have a recurrent laryngeal nerve injury. So how many have I done? More than 200. How many times I've had voice injury? Twice. So I agree with this. 1 out of 100 will have a voice problem. Why? We don't know. Italians have a lower number, but I believe this number based on my experience and what they're reporting. This other stuff, hematoma, these are minor complications, they go away. This doesn't really happen, has not happened to me. Skin burn can happen because if you get too close to the capsule or you're zapping the area outside the capsule, you're not very good with looking at the needle, or you've missed where the antenna is. Hot liquid and gases can escape the track and give you a first degree small superficial skin burn. That can happen. Brachial plexus injury has been reported. Again, I think that is because of lateral approach. If somebody went behind the vessels, I don't see it happening otherwise, but it has been reported. Nodule rupture, very rare. And this is a scary complication. This will happen 3 or 4 weeks after the treatment is done. And again, no predictors again about which nodule ruptures and why. And nodule rupture will present with a sudden bulge because the liquefied and ablated stuff will just bulge outside the thyroid. Soft swelling in the neck. How do you treat it? Well, the Koreans give them antibiotics and high dose non-steroidals and compression and cold compresses, and it goes away. 1 or 2 patients had an abscess formation. I believe they did surgery on them in Italy. These guys just do it conservatively. So that's uncommon. Most common complications up here. That's 1 out of every 100, in my opinion. And according to this data. Now, what happened to these people before they started doing hydrodissection? Well, 13 of them followed up, and all 13 had recovery of the voice within 2 months. So it does come back. But if you're a singer, you're a teacher, you're a doctor who uses their voice, that 2 months can be pretty hard. So there's a way of reversing this during the procedure. I'm going to talk about it in a minute. So this is the Italian version. And they looked at 337 patients. So smaller cohort, but their results way better. So voice change 1, nodule infection 1, minor stuff, edema, hematoma, blah, blah, blah. They're reporting a complication rate of 0.4%. That's very low. And compare it to this study, it's about 1.4%. So it's still very low, right? He just told you about surgery. Inexperienced surgeon, low volume surgeon, 9% chances of voice changes, 9% chances of complications. Permanent hypoparathyroidism between 3 and 5%. You're on Rocaltrol the rest of your life. So stuff happens in surgery, even in the best hands. This is way safer. Way safer. That's a remarkable number. Now, let's move on to the equipment and the settings. So you have the stuff right there. You can see it. That's the pump, and that's the generator. Now, right now in the US, there are 2 RFA systems. There's a laser system, and there's a microwave system. And we also have HIFU in Italy and France. I don't think that's ever going to make it here. I can briefly tell you what HIFU is. The HIFU is high intensity focused ultrasound. Do you guys use it at all here? You guys available? Okay. So think of a magnifying glass. You put a magnifying glass, we've done that as kids, on top of a piece of paper, and you focus all the rays of the sun on a piece of paper. Paper goes up in flames after a little while, right? We've all done that. A similar concept with ultrasound. If you can focus all the ultrasound beams on one area just by putting a transducer on the neck, the vibration effects of the ultrasound waves will cause the same thing that this is doing. Friction heat, 60-degree temperature, cell death. So that concept is being used on thyroid nodules also. The problem is, as soon as you move a little bit, you got to restart all over again. And it takes a while to heat up that little area. And when it is used for prostate cancer, for which it is approved in the US, and I've attended a couple of those procedures because I was trying to adapt that for the thyroid because nobody in the US does it. It took 3 hours to ablate a prostate cancer nodule this big. And so it's not really worthwhile. Microwave has been approved also. Microwave, you cannot control the temperature as well as RFA. You can get up to 300-400 degrees sometimes. There are other advantages to microwave because you can do it in people with pacemakers and pregnancy and stuff like that. You don't need internal cooling, but I think the temperature regulation part is harder. Now, have these been compared head to head? Of course they have been. Of course they have been. Laser is inferior in terms of volume reduction, but RFA and microwave are pretty similar to complication rates and volume reduction. Laser has about 15 to 20% less volume reduction and more regrowth. It fails a lot, but laser is cheaper and easier to master. It's very easy. In laser, you just basically put the fibers in 2 different places, and now just leave it be, turn on the machine. So it's not as flexible. You can't reach all the areas. That's why it doesn't shrink as much, and regrowth can happen. So the electrode is right here. This is the electrode. This is the one I use. The other system is also out of South Korea. And I believe there's some Chinese companies which make microwave antennas also, but these are thyroid specific antennas. So they're thinner. The ones I guess you use for liver are probably bigger, 14 gauge, 13 gauge, and bigger tips and stuff. And so the other beauty of this antenna is that this tip is really sharp. It's a really sharp tip that they have in comparison to the other modalities I've used. So this makes it very easy to move around inside the nodule. That's been my personal experience, and so my colleagues also who use this in our practice. The different size tips, that they're available. This is an idea. The bigger the antenna, the more energy needs to be delivered. Smaller antenna, lower energy you can start off with. But for smaller tumors, you use smaller antenna. For bigger tumors, you use bigger antenna. There's also a flexible one, which there's a thingy on the handle. You can adjust the exposure tip by moving it up and down. I don't know if that's available here, but it's available in the US. It feels a little tricky, so I don't use it that often, but it can be used. Always at the head on the bed, grounding pads, neck exposed, sterile procedure. You have to have sterile gloves. You have to be very careful. But as you saw from the complications, it is uncommon to get thyroid infection. And I think that's got to do with the fact that the thyroid gland is full of iodine, and betadine is what we use to clean the neck. So I think iodine is a very good antimicrobial agent. So, and thyroid gland is very vascular. You still see subacute thyroiditis here and there, in patients. So it's possible to get infected. So do the best you can to have a very sterile field. So sterile drapes on top of the patient, sterile cover of the probe, sterile gloves, mask, all of that stuff. Just like you do central line almost in the ICU. So how do we get this stuff done in Pakistan? I wrote these slides and I was thinking about this talk. There are some barriers, the financial barriers. I can't project into the future, but I feel that if there's enough people doing this, I think that locally we can figure out a solution to have a cost affordable antenna, one way or the other. I feel that that's possible. Not now, I mean, not next year. I think long term we can make this affordable and available. So I can't talk about the financial barriers. I can talk about them in the US context, and now in the US most private insurances have started covering it, so it's not that big of a deal. They don't have to pay it out of pocket. The insurance is covering it. So technical aspects, well, that's why I'm here. We're going to work on the technical aspects. We're going to learn this. Hopefully you'll watch one, do one, and then teach one. So that's the hope. You guys will basically teach others, and then this will become normal. And all these patients with this distress, this fear of surgery, and these big goiters, especially young ladies, they don't have to, deal with that anymore. So hopefully this is what's going to happen in the future. Training is an ongoing process. This is just your primer. You will learn more when you do it yourselves, and it'll take maybe 30 to 50 cases before you feel really comfortable. In the beginning, if you feel less confident, which we should be very humble about this. We're treating real patients. We can make mistakes. Try to do it with another colleague. Most of my cases I do with one of my other partners. There's a few endocrinologists in our practice. So because two heads are better than one, we can both visualize the screen. We can both switch off with large nodules because your hands start to cramp after a while with these precise movements. We switch off. I can do it myself also, but it makes it much easier if you have another person with you in the beginning. It became so much easier that we typically schedule one day for RFA, and two of our partners, both of us are doing RFA today. So we do 6-7 cases and the other people see. So that helps. So the training will help if you guys, you guys can work together. Generator cost, yeah, it's expensive in the US. It can vary the cost. I don't know what the costs are here, but I can tell you that most countries around here are using this. This is common in India. This is being done in Kazakhstan. This is being done in Vietnam. This is being done in, Laos. Most of the countries in Southeast Asia that are at our level economically, they have this available. So this can be done in this socioeconomic context. Can be done. It's not like that this is not affordable in Pakistan. Can be done. There are other countries with our same socioeconomic status in which this is available, and they're doing it. We have to figure out the ins and outs of it, but I'm saying the other people are doing it. Staff time, supplies, these are small parts of what it costs. Reimbursement structure in the US, this is what it is, and it costs between here and here, but private insurance companies are now covering it. This is stuff we need for tomorrow. We need some drapes, we need some syringes, we need some lidocaine, stuff that you guys use in IR all the time. I'm sure it's going to be easy. Clean the neck, ultrasound cover and gel, some saline, and D5W has to be available. There. Skills to practice before your first case, because not all of you can do these cases tomorrow with me, but learn to do this. Every time you do a biopsy of a really large nodule that you think is going to take some time, instead of just doing it with lidocaine under the skin, tell them like, this is going to be a little painful. Let me do this for you. Learn this. Learn doing biopsies from the head under the bed. Learn how to do this hydrodissection. This takes some practice. And after 10 or so these, you'll be like, yeah, next time when I actually do RFA, this is going to be a piece of cake. I can do this. Okay. Try doing biopsies transsysmically, just like Dr. Rana was saying. Those are things that can help you. And then obviously we're going to practice in the phantom today, but it's not similar to doing it on the real patient. So thank you. This is our team. We were doing some of the toughest cases back in the OR when we were doing cancers there, but these are my partners and my colleagues in my team. So we don't see you. Well, so with COVID, I can't wear a mask anymore. With the mustache, this just doesn't fit. Plus, ski season is starting, so you don't usually have that when ski season is there because this freezes. It becomes really painful when I'm skiing. I ski a lot. That's why I live in Salt Lake. So I ski 2 days a week. All right, so this is a real case, guys. So as you can see, we're doing ablation in the inferior part of the nodule. We're pretty close to the nerve, but we're far away. You can see the tip. And we're asking the patient about her voice. And right about here, voice goes out, like it becomes hoarse. And so when that happens, you got to stop the procedure. And so we did stop the procedure. Now, what do we do next? Well, we have to cool down the nerve rapidly because the voice will respond. And so you use a 25 gauge needle and you go transesmically and you get to the tracheoesophageal groove. And so you can see the needle going in. You can barely see it, but it's coming in from here to here, just like that. It's going to go transesmically into the TE groove. In a minute, you'll see it. You can see the needle shadow up here. We're almost through the thyroid parenchyma, almost. And you can see the tip almost here. So now we're behind the thyroid. And now we're going to start injecting really cold D5W. And you can see this area expanding a little bit. And there's more fluid. You can see a little area develop here. Bigger area now. And this is about 10 cc's. See, this is expanding, this whole area. Everyone can see that? This is all fluid. This is the tip of the needle. And by this time, voice came back to normal. So thyroid has been pushed way up here. This is all fluid. Voice is back to normal. You take the needle out, stop the injection, and you go back to ablating what's left. And you check their voice 2 weeks, 6 weeks, 7 weeks later. And it's been normal since that time. So this is what you do. Now, Professor Baker has actually published on this in ENM, 17 cases, but in the US we've never done it. And there's no standardized technique. We think this is how it should be done. You just go straight through, get to the groove, inject, voice comes back to normal. And you go back to doing what you were doing. I do know it's going to be more affordable. That's all I can say with time, just like those plasma TVs. Yeah. Yeah, it's a very common question we get. No, we have not. But I don't typically ablate people who are thyrotoxic. As a thyroid specialist, I want to make sure that they're not symptomatic. So if you have a toxic nodule with free T4 is twice upper limit of normal, they're on tapazole, they're on PTU, they're on something to get their levels normal so that they have good quality of life before I go after it. So I'm not going to ablate somebody who's got thyrotoxicosis going on because that's more important than managing that for quality of life and all of those things. So you control that before you do this stuff. But for patients with pre-toxic nodules, I don't have to treat that. Do you know the concept of pre-toxic nodules? A pre-toxic nodule is the TSH between 0.1 and 0.4. It's not high enough to give them real serious symptoms. Their free T4 is normal, but they have a problem. And so that's a pre-toxic nodule. In those situations, I'm not going to give them any medication. But while treating them, are they going to encounter a thyroid storm or something? No, I haven't tracked free T4 levels the day after and stuff. We just check their levels 6 weeks later. By 6 weeks, there's been a 40 to 50% decline in thyroid levels. And typically for toxic nodules, as I said, less than 12 cc's, by 3 to 4 months, their levels are normal, completely normal by that time. For nodules that are much bigger, the levels drop by 40, 50%, but it'll sometimes take more than one treatment, or you have to wait a year or two before they completely normalize. Because bigger nodules will take a lot more energy.
Could we start high dissection before starting the RFA?
To protect the nerve in a benign nodule? So it's 1 out of 100. You're going to do it 100. The number needed to treat is 100. If you look at biostatistics and publication, that's not a good NNT. That's a very high number. So I don't think you should do that. I don't. So.
For toxic nodules, when do you stop the medication or do you stop the medication?
So after I do the procedure, I tell them to cut the dose by half, and I'll check the levels in 6 weeks and go from there. So the thyroid hormone has a half-life that is, a few weeks at a time, right? So it's not gonna they're not gonna become hypothyroid just because you did this. Remember, because the rest of the thyroid is normal, it'll start, normalizing everything. So you reduce their dose by half, and then you have them come back in 6 weeks, in anticipation because the levels are gonna drop. So we give them Motrin after that, 800 milligrams for 3 days, just to decrease the inflammation. We tell them to ice it. That's it. We tell them not to bend over and do any, deadlifts or any straining and stuff, so the neck veins don't pop out, because that nodule rupture stuff that has been mentioned. People went back and asked them, what did you do different? What happened to you? Why did this thing pop? And one of the illustrative cases is this one lady in Italy who went to, Professor Valcavi up in northern Italy, and he got this thing done. I think it was one of those colleagues in Italy. And then she went on a horseback riding trip for 1 week in Iceland after that. And then she had a nodule rupture. So we're like, there's some sort of physical strain also. But there've been nodule ruptures in Korea also, and there's a paper published on that, a small series. We don't know why it happens. Not really clear. But there are different types of dissection: anterior, lateral, posterior, different areas that it can pop out of. But it's very uncommon. As you can see from the list, there were few single-digit numbers that they've been described. We haven't had one in the US so far that I know of. I've never heard of that. As a cause of like hematoma around that? Well, it's after it ruptures, not to my knowledge, but it's a huge mess after that. The whole thing, if you look at the ultrasound images of the ones that I've seen that rupture, it's just a liquid hematoma type reaction you're seeing outside the thyroid capsule. It's like a mushroom almost, going outside the thyroid, kind of like that. That's what it looks like. But that's a delayed complication. So, but those are rare, very rare. The things that you worry about is the voice. That's the most important thing. That's the thing that happens most commonly.
Do we use antibiotics in this procedure?
We don't. Sterile procedure, never had an infection thing, knock on wood so far. Yeah. So we don't use that. So
What's the length of intervention?
So there are different lengths available. I think the ones we have available here are 10 centimeters. The one I use is 7 centimeters in the US. So they make different lengths. But if you look at how deep these things are, that's 3 centimeters in. And if you look at the ultrasound, all the time, yes, absolutely. Yep, we hold it all the time. Yep, yep, we do. We do hold it all the time. All right, guys, thank you so much for listening. I think the next step is we do some hands-on stuff. Is that what we're going to do? After. Perfect. And I'm here. You can just ask me any informal questions too.